Dream machine. .com, H07, I-18 in the snap. We're building the future, never looking back.
Welcome back to Imaging Informatics Unplugged. Today, I'm joined by Rishi Nayyar, co-founder and CEO of Pocket Health, for a conversation about the evolution of image exchange and the curious reality that in 2025, someone somewhere is still handing patients a CD as if they just joined Columbia House. In this episode, we talk about how a sprained ankle set this whole journey in motion, why Ditch the Disc hasn't quite ditched the disc, what it really takes to give patients control of their imaging while keeping providers connected. Rishi also shares how Agentic AI is starting to reshape radiology's non-clinical workflows, automating requisitions, scheduling, and image ingestion, and how to build trust in systems that can now act instead of just analyze. So if you've ever held a CD that said imaging, you wondered, what century am I living in? This episode's for you. So sit back, hit that bell, like and subscribe. And with all that said, thank you very much, Rishi, for joining me today on Imaging Informatics Unplugged. I'm looking forward to this conversation. So I want to start at the beginning. I met you a long time ago, and you were not in healthcare way back then. You were at the banking sector. Your brother Harsh was at Google, I believe. And so you're not in the midst of the challenges that healthcare was from a vendor side back then. So what got you into this area where you wanted to tackle the access of patients being able to get their own images? What was the moment?
Yeah, it's a great place to start off. And Jason, thanks for having me on. The story started with, as you mentioned, my brother, who also didn't have a healthcare background, but he was playing tennis. We're not a very athletic family, so he tripped, hurt his ankle, and as is inevitable, and he got a MRI and an X-ray to help diagnose what's going on. And at the end of that appointment, he walked out of that clinic in Sunnyvale, California. This is back in 2015-ish, and they handed him a CD. And I think that juxtaposition of just, Netflix up the road and YouTube down the road. And meanwhile, this data that he wanted to get access to, his physician needed access to, was being handed to him on a CD-ROM, was pretty stunning. And he called me up, and I felt that it was the right time for me to do something entrepreneurial as well. We wanted to solve a problem, and we thought, why don't we start with automating a key piece of the workflow. This one was interesting because it's a key piece of the patient's workflow, and also a key piece of the clinic's workflow or the hospital's workflow, because they don't want to be burning those discs anyways. And that was a jumping off point for what I would say is like a pretty broad automation effort now across Pocket Health, but that was the genesis of it. So we formed the company in early 2016, and he sprained his ankle. This must have been about a year and a half earlier. Yeah.
Okay, so we've got 2016. That's just before the big hype around Ditch the Disc and that big campaign that we saw in the States, the ACR campaign. We could fast forward now. We're almost a decade out from then. There's a lot of standards. We're in Canada. Canada has these regional imaging information exchanges, but we still see these CDs around. And I'm curious, what is your thoughts around why we still see this archaic technology lasting on longer than we would think it would?
Yeah, there's really let's probably say three reasons. One, obvious one right off the bat, patients are often excluded from these systems. If they are included in the systems, it's really brutal UI that clearly is just a reskinning. We've seen where they take the physician portal and make it pink, and they say, oh, this is the patient view. Now, with a full diagnostic viewer, I've seen portals that require the patient to download Okta, if you can believe it, and to download it, I guess someone in legal got their hands on that as part of the approval chain. So there's that piece. The other piece is really they think top down. So when you think about broader efforts at the state level, et cetera, they're trying to create a top-down system, and the infrastructure is there. The infrastructure typically is quite solid, pretty well thought out. The application layer isn't. So that's where things fail. And, we see that closer to home sometimes as well. And then lastly, emphasis on network-based sharing is just far too strong. So you have a lot of traditional players in the space where they have built their system on the premise of, if I have this node and you are on that node, we can share images effortlessly. And of course, that's how IT works. The nuance is when you aren't on the same node, you aren't on the same network, and how do you share that way? So we invested a lot into solving those three problems. You still need a network-based sharing solution. You still need all of that to work properly, but we tried to build bottoms up that worked at the application layer. We obviously started, as you mentioned, at the patient level. So we build a very strong patient application as well. A lot of CDs go that direction. So you cut those CDs out. And then lastly, these types of one-off shares or one-off retrievals need to work really, really well. And I think we've done a good job there.
Okay, so maybe that's a good jump off point for my next question around patient access versus provider access. Patients love to feel empowered by the ability of accessing their records. I'm curious what your thoughts are around efficient image exchange, and if that really is serving the purpose of image exchange, or is it just getting custodianship back into the patient, or do we really need to focus on provider to provider more to facilitate specialists getting what they need and so on?
You have to do both because they're very different use cases. The patient use case is to satisfy two purposes. One, the patient wants control of their own data. It's a very large percentage of patients. If you don't give them control and meaningful control, it means DICOM, it means full diagnostic quality, downloadable, they can view it, etc. If you don't give them that control, you will still be burning CDs because you will have an increasingly growing cohort of patients who want that. And a JPEG viewer or a PACS viewer in my chart is not satisfactory. Like they want the actual access, but like a CD-ROM would give them theoretically. So they don't want to downgrade into PNGs or a diagnostic viewer that they can't download or share from in my chart or Cerner patient portal. The other piece is when you give it to the patient, it can follow the patient. When you focus only on provider to provider, you have to know the end destination, and you often know, but anyone that's been in the film library or anywhere else knows that you often don't know. So the patient kind of covers your butt that way. Then you also have to have the provider to provider case. So, when we started, we only did provider to patient, and then you're still burning CDs because there are many patients who are dealing with a significant health issue. I don't want to be in charge of moving my data from hospital A to hospital B. So you need to cover that use case as well. I think the issue is that a lot of people only focused on that provider to provider use case and missed all the other pieces that I started talking about here. So you really do have to focus on both. We're on implementation 800 by now. We've seen it. If you do one and not the other, and it doesn't matter which one, you're not going to get the CD burning reduction, and the project's not going to look as rosy as when you thought when you started out.
If we think of the, that patient access, there's a spectrum of engaged patients. Do you have data on your side that represents how frequent are patients truly engaged, or is it more of a safety net that I have these images, like I've used your service and I have them, and it's great, but I don't really check in on them. I'm not going through it. And I'm curious of the level of engagement this does provide. Do you think it stimulates kind of new participants that may not have been engaged as much before?
Yeah, at the moment of care, they are very, very engaged. And then how much engagement happens in the weeks that follow depends on their healthcare journey. So we have cancer patients that are logging in every day. They're reading their results, they're getting second opinions, they're looking at some of our AI translations, they're trying to understand what to be doing next. We have patients it's an MSK issue. They get it figured out, and there's no reason for them to log in again, and that's completely fine. But the main point is that I think we've proven with our data that patients find a lot of value, but it also drives ROI. We spend a lot of time surveying patients, talking to them, and building pretty large-scale research studies on the platform. We have over 2.5 million patients on the platform now, so we've proven that when patients see follow-ups that we've been able to highlight, those are follow-ups that they didn't know before and their physician didn't know. And we also survey them on their likelihood to book it. And typically they would not have been booking it otherwise. We talk about call deflection and how understanding what their report means saves, at a typical hospital, thousands and thousands of calls coming in every single year just by having Pocket Health explain to the patient. So it's not just about doing what's right for the patient, but I think health systems are starting to understand that if the platform wasn't doing it, your staff would be doing it. It's not like the need would just go off into the ether. The patient will be demanding that question is answered somehow. But that engagement level really, definitely it's our patients that are sickest, going through the most complex care, your cancers, your heart issues, things like that, where we see the most engagement.
Okay, and you mentioned making the report understandable for the patient. So years ago, you and I and it was Dr. Teresa Carreras. We were on Simcast, and we were having a conversation about patient access, and they had Porter. I think this is UPMC or Penn, and this was this ability to translate and do lay reports. But this is before AI. This is before LLMs, or like AI was here, but it's not in the way that we see it now. So that approach that you've taken as far as making a lay report and making it more understandable, can you talk us through that, and where does AI, if it does, play a role in that process?
Yeah, we take different steps, some deterministic, some probabilistic, and the patient can kind of slide that slider up and down. So think pure deterministic. As they're reading the report, we're actually able to underline words, click on it, they can understand it, we illustrate it for them, all that great stuff. We now, when it's an anatomy, we actually find that anatomy that the report is referring to in the images and segment that out for the patient. They can, and we're talking about anatomy. We're not talking about a diagnosis. So if there's a node or something like that, we think it's more appropriate right now, at least, that the physician's able to highlight that for them. But where your heart is, where your spine is, your left lung, if there's something going on in a particular, especially like a nuanced anatomy, it's really helpful for the patient to understand what they're talking about and orient themselves around the image. And then recently, we launched what is probably our most popular feature ever, is report explanations, where we spent a lot of time working with a number of our academic health systems to basically create an LLM translation into patient-friendly language of the reports themselves. So obviously, we spend a lot of time at the onboarding of that feature to help patients understand its limitations. But at the end of the day, it is a really, really robust patient-friendly translation, including especially of the impression, which is critical, and any follow-ups, and much better than what patients would get if they're going to a traditional LLM, because we spent a lot of time on fine-tuning, refinement, working through the prompts, and making sure that we're staying in a safe zone there and not speculating, not going to do a translation and not go outside the bounds at all with what the RAD was saying. Is easier said than done, takes a lot of training, takes a lot of effort, and a lot of validation.
Yeah, like you said, I imagine there's certain things that are just pure deterministic, and then that's a really cagey area to be in when you start opening up to probability and not going beyond the boundaries of what the report of the intended diagnosis was. Yeah, I always think when I hear that my liver is unremarkable, I'm like, what do you mean?
Yeah.
Unremarkable.
Yeah,
A liver.
I think it's
What are you
great.
talking? I'm interested in other areas where you've looked at AI, and whether it's in the past couple of years as we've seen adoption with LLMs. Is there anything related to that, or even on the agentic side?
Yeah, our biggest scope of work right now is workforce transformation using agentic AI. So we started off with replacing the film library. I think we've done that successfully at hundreds of large centers now. We're now pushing to automate the entire non-clinical journey. So Jason, I think you've spoken to a lot of great companies that are spending a lot of time and effort on automating the clinical workflow. That means helping RADs read faster, triage better, faster, whatever it happens to be, and all the workflows around there, even just work list, hanging. There's a lot of effort on making the clinical journey. We think there's not nearly commensurate effort on making the non-clinical journey as automated as possible, and that's where agentic really shines. So we have a platform that has now expanded from a couple of years ago, just film library, to the entire end-to-end patient journey. So requisition comes in, the AI reads it, it's able to go look up the patient, create a new patient if needed, if not, merge them together, create the order, coordinate properly with the pre-auth systems or pre-auth teams as needed, push it to protocoling if needed, and then go into self-scheduling. That's the patient getting an AI voice call, SMS, interactive SMS. So truly replacing all of those steps and then getting the patient to the appointment fully prepped where they're supposed to go, and then all the steps after as well. So replacing the entire call center, all of the inbound calls, whether those are general FAQ calls, pulling up where's my report, where's my images, I have a question about where I can park, everything there. So the amount of labor and the amount of spend in the non-clinical areas actually far exceeds in the clinical areas. And we're excited to actually have a system that's able to be the OS for all of the non-clinical workflows in radiology, with a focus on not augmenting, but truly replacing the human efforts there.
I'm curious, because it sounds like initially Pocket Health starts out as this image exchange method. I love the journey of organizations as they grow and take on kind kind of new opportunities. So now you've encompassing kind of a mastery from order scheduling all the way to results distribution. When it comes to a lot of these automated processes, and when we're sharing exams, one of the things I did not like about the ditch the disk effort was focused on eliminating the physical media, but it did not necessarily focus on automating the mechanisms of getting that image into the packs, because you've now just replaced the ability of importing outside images from physical media like a DVD or CD into now I have it on the cloud and I have to reconcile it against an order and make sure the names match up. What efforts have you made on automating that inbound process to kind of smooth that out as an experience of the ingesting site?
Yeah, we've fully automated it. Yeah, I think that we really take a lens on what our clinical team's doing now. And a common refrain is like, yeah, now we don't burn that many CDs anymore, but the imports are killing us. Mm-hmm. And often it's your highly paid PACS admins who are doing that work, not your clerical staff. So it involves a lot of flexibility because sites have different rules. Are you creating the order or not? Where do you get the accession number from? Creating the order, do you create the accession from a namespace and push it in there? Do you form a HL7 message from the DICOM attributes, push into Epic, listen back? There's a lot of different approaches. Do you push into a dirty PACS and then hold it there just so you can quickly view and then reconcile later or never reconcile? Or do you want everything in just one kind of, let's say, production system at all times? Do you notify the physician or not? There's a lot of steps in there. You can do a lot of it through traditional DICOM, but with Agentic, it actually lets you do things a lot faster because you can do lookups into systems and get information that you didn't necessarily have access to before. For example, pinging the physician. You might have to leverage a system internally in the hospital that the EMR doesn't give you access to, but Agentic AI actually leverages the clerical GUI and is able to push out a message that way. So there is, especially if you think about your kind of better known specialized healthcare systems and the pediatric systems, they're importing more than they're sending out just because of their nature. And they have very, very large teams that are working on this reconciliation problem. Before Agentic, we spent a lot of time and we're able to get basically 90% of the way there, and now we're 100% of the way there.
I remember a study saying that, and this is when it was CDs, but the time to import a single study roughly took about 10, 30 minutes. And so you eliminate the CD, you haven't saved much of that time at all.
Yeah, because you're doing MRN matching, then you're doing order creation, maybe not. A lot of orgs try to get out of the order creation step if they can. That's often not possible. Then you're doing patient level DICOM tag morphing. Then you're doing study level DICOM tag morphing. And then you have to make sure it went in properly. It's a lot of steps. These are all automatable steps, but you need to kind of go through that process.
I'm curious, do you see a favorite approach when it comes to your customers, your sites, when they have ingested the exam? Do you tend to see that they set retention rules on those outside images and they'll blow them away after 2 weeks, or do they keep them forever?
So once it's in, they typically will keep it until the next migration. And it's kind of this weird line in the sand that we started to see. You have, especially large centers, are very afraid of becoming the region's HIE accidentally. Where, hey, if they have it and then they're connected via Pocket Health or another image exchange to all of these other spoke sites, those spoke sites will say, great, we don't have to store these images. So there's a little bit of that. They're very careful about what they pull in. But once it's pulled in, we find that it's typically it's tough to delete something. Even just running a delete operation, I think, gives people a little bit of stomach pain. But when you're doing a migration, and migrations happen all the time, that's typically the opportunity where they say, look, why don't we leave this data behind?
Yeah, it's funny. I remember when I was working with the regional repositories, sites, the path ended up going down as a kind of a quasi-standard to delete after a set period of time to mitigate the opportunity of having stale data if something's changed since the point of ingestion. And so but I've also seen like very strong philosophical approaches in other provinces that look the exact opposite of that. So it's an interesting approach. I don't think there's necessarily a right answer. Have you looked into discrepancy modules? So if something is collected at a certain point and then you identify, like, is there any mechanism that you have in place to be able to track that something has changed, like an addendum was added or something like that at the source site?
Yeah. We have that ability. Interestingly, very few sites enable it because the point in time release also has a lot of, you could say, like legal advantages as well. You really are only intended to act on the data you have access to or that you have in your system. The second you have a real-time sync involved, you need to make sure that then someone's informed about that addendum. And the current legal paradigm is well oriented around point in time release. And that's not an imaging thing. That's just around all health data. That's how all health data comes in. It's not a real time sync. So it's an interesting thing where it's not the tech. The tech is available. It's the, I guess, just comfort level, willingness to lean into it.
Okay, so I'm going to close out with one last question about agentic AI and along the lines of trust. And I'm curious from your perspective of, because you would see this firsthand, of the willingness to accept, the willingness for customers to trust agentic AI in certain types of decisions. Now, it can have negative consequences to patient care. What are your thoughts around this, around building trust and safety as we approach agentic AI?
Yeah, we are talking to hundreds of health systems about this every single quarter. And what is obviously clear is that, one, it is extremely disruptive when things go wrong, because these health systems are somewhat well-oiled machines. Radiology is no longer a cost center. It's often driving revenue. They spend a lot of time trying to get every half point of scanner utilization up. And one day of scheduling not working can blow out all their results of that for an entire quarter. So I will say the feeling we get is that, unsurprisingly, the stakes are very high. What does that mean? It means that you need to find a way to bridge these workflows with getting comfort level. A lot of times that means that every single thing that does not need to be probabilistic and agentic should not be. That does not mean that you cannot use agentic workflows to map out an RPA or APA and then swap to deterministic code, which is what we do in a lot of situations. It doesn't mean you can't have an AI monitoring layer or even self-healing on top of that, which makes these automations much, much more resilient. As you know, the typical, shortcoming of traditional RPA is that they're extremely brittle. Epic moves a button from the left to the right and the entire automation breaks. Which is, imagine you had a staff member who's like, well, the color changed to green. You say, well, you still click it. It's the same thing, just click it. And so we've been able to solve those problems at scale. It also means it's really around proving that the guardrails are up, that you can train these like you train humans, and then letting them spend as much time as they want with it. So in our speech software, we just say, hey, call the agent. Talk to it, take it off the rails. You talk to your patients all day. Say things that, put in your craziest patient story and see how it responds. And is that better or worse than what a staff member would be? And I think that that's the only way to do it. We're coming into health systems and we're not replacing another software that they have doing it. They don't have software doing it. So we're really, really on the cutting edge. I think that you have to give the industry grace. You can't pretend that they are listening to agentic AI podcasts and every time the new state-of-the-art model comes out, they spin it up in their environment and they try it out and they look at the benchmarks every day, and that's not the world they live in. They're trying to deliver great patient care, quality, do it in a way that actually keeps their health system afloat, which is harder and harder every day. So you have to really kind of lead them through that process.
And when we're at RSNA, and we'll see lots of posters for agentic AI, and they'll have to cut through and the signal to noise ratio on some of this marketing versus reality.
It's like go up to the salesperson and say, like, what do you mean by agentic AI? And just see if that squares.
So you will be at RSNA. Feel free to close out if you want to. We'll get this up next week, so there's an opportunity. You want to say wherever you're going to be in the next little while.
Yeah, definitely. We'll be at RSNA. We'll be chatting about our entire automation suite, from patient interaction automation with Patient Connect to DICOM automation with our image exchange platform, and lastly, our back office automation with Pocket Health Conductor. So we're really excited to be walking through all of that, doing some live demos. We'll let you chat with the agent or receive the SMSs and kind of work through that. So we're excited, and it'll be a very, very busy couple of days.
And thanks a lot, Rishi.
Great. Thanks, Jason.
Dream Machine.com, HL7IHE and Snap. We're building the future, never looking back.